Thank you all for coming and attending. Um, so the big news is now I have a grandson, and he's only 16 months old, but I am starting to get him to be a statistician. We should have been here. Thanks for reminding that we started in 1997. So last year would have been the 25th anniversary. But every place is delaying 1 year because of COVID. So this is the 25+1 anniversary then of this. But Tambu asked me to just give just a very brief, short presentation of why an RCT. Why do we even care about RCT? So basically wanted to give you a short introduction, a little bit of humor, but a little bit of seriousness as to why we care so much about RCTs. Basically because we want to establish evidence that something is causally related to some outcome. And this is what has been behind all of this. Most of clinical epidemiology is to understand how different exposures are related to a particular outcome. And we are very much interested in doing this. We want to be able to understand these relationships. And we want to know the causes of things. We want to know why something occurs, when does it occur, and where does it occur, how severe can it be, and the causes of its cure, mainly because we want to either prevent it, treat it, or cure it. You can see here, for example, a complex web of causation for COVID. And we all have suffered through this. We played through this. In fact, one colleague of mine who's a public health researcher said, you know, everybody's treating COVID as if it's gone. And he said, no, COVID has never gone anywhere. COVID is still here. The only thing that has gone is the people's patience with public health practices. That's the only thing that has gone, but everything else is here. So we're interested in knowing these causes. We want valid results. And during COVID, we did get them very quickly. We had platform trials that was done. I don't know if you've heard about the recovery collaboration group. This was essential in the early stages in the UK to be able to understand what treatments were not working and to discard things very quickly. And so the recovery collaborative group did platform trials. So you can sort of add on to things and the same design, now you replace it with another drug, for example, when you show that something's not working. We also had very quickly, once the mRNA vaccines were developed, had to show with clinical trials that these things were effective in reducing the symptoms, okay? We needed this because we wanted valid results, results that were not unbiased, that were unbiased, sorry. We also want current results. We now have techniques, and Tambu will probably talk about this, of living systematic reviews, network meta-analysis. This is one, you can go to the BMJ page right now, and daily, as new studies come out, they are now being able to tell you what is the evidence of what is working and what is not working. So we want these things. The public demands this. That's why we have these clinical trials. RCTs are looked at the top of the research evidence hierarchy because nobody now trusts anybody. So expert opinion is not considered evidence. We have case series and case reports. We initially had those when COVID started. And we have details of factors in the cases, but we need a comparison group. We can look at trends in the cases over time. But then we have the traditional observational studies, like the cohort studies, the case control, and the cross-sectional, which will give us some information about the association between the exposure and the outcome of interest. incidence, prevalence, but that association is important. And we may even have replication of, but it's not until we do experimental designs. Quasi-experimental designs are ones where you don't randomize. But if you randomize, now we have the strength of statistical um, validity or integrity to be able to establish causal association. That's why we're going to be talking about that in this course. Then we also have replication of the causal ones with meta-analysis and systematic reviews of RCTs. So why? Why do we want to know this? Well, because we think something will be helpful, something will work, and we need to convince people that this works. Now, usually convincing people may be hard, may be easy. If people are convinced by you saying so, then fine, an RCT is not needed. An RCT is not needed either when the intervention is dramatically fantastic. When Jonas Salk did his study, he didn't randomize anybody. He didn't do a trial. He basically inoculated himself, his wife, his kids. That was it. They didn't get polio. Was convinced of all I'm told. There were later trials came up later. The first clinical trial is attributed to James Lind, who was a physician on board of British ships in the 1800s that were going around colonizing the world. And all of the British sailors were getting scurvy because there would be long times at sea without anything but meat and potatoes and other things, but they were not getting this vegetables. And he took 12 people that had scurvy and he assigned in pairs, two of them, at least he thought about replicates, and he gave some of them vinegar, he gave vitriol, he gave seawater, whatever came up to his mind, and two of them he gave oranges and lemons, and they became okay. And that was what proved that you have a very, very strong effect, very little variability, and so things work. If variability is zero, an RCT is not needed. And this is a tongue-in-cheek one, but there is an article in the BMJ by Gordon Smith that said the parachute used to prevent death and major trauma when you jump off a plane has never been shown to be true in a clinical trial because there's zero variability, right? Anybody that jumps without a parachute is going to die, and people that go with a parachute, you die. But this was a joke, okay? And the BMJ likes to have jokes in December. They always do this at the end of December. And so somebody else more recently did this trial, did a trial where they recruited people to jump off a plane with a parachute that worked, and the other ones with a placebo parachute. They had a very hard time recruiting people for this, as you would imagine. But they did the study and they showed that there was no difference because they jumped not from high above, they jumped from just half a meter, right? So people do these things because people take clinical trials maybe a little too serious. And I think this is what I think is very important. We're going to be going over the methods for clinical trials, and we'll be very serious about it, but there is caution on this. Not everything requires a trial, and you can get decent evidence from a lot of different studies. The reason we do trials is because we need to convince people that are hard to convince, right? And so beware of the religion of trialism. Religion of trialism, they believe in the Holy Trinity that's different from the Holy Trinity. They believe in the clinician, the patient, and the biostatistician. This is all tongue-in-cheek joke, but it was published. So the patient believes that the physician is God. The clinician believes that the P less than 0.05 is God. And the biostatistician, they say here, believes himself or herself is God. But all religions have a devil. So what is the devil? The devil by the patient is to be randomized. The clinician believes that the devil is the p greater than 0.05, and the statistician believes that sample size of 1 is the devil in this case. So joking aside, they have 10 commandments of a clinical trial, and these are actually serious and good. So number 1, thou shalt randomize. That is essential, and you will see that when we talk about this. Thou shalt double blind. You want to prevent the potential of biases. Thou shalt not do unto a patient that which thou would not do unto thyself. Ethics. Ethics is actually going to be what guides most of what we do in clinical trial because we are experimenting with humans. Thou shalt commit consecutive patients, so you don't do all this bias on who you select. Thou shalt follow the protocol. Adherence, compliance is important. Thou shalt complete all clinical forms. You don't want incomplete data. Thou shalt use appropriate statistical evaluation. That's where we come in. Thou shalt seek answers to only a few questions. Don't do too many questions in one because you're now spending so much time collecting all sorts of things and you're losing track of the one important things. There was a fantastic paper back in 1973 by Yusuf and Pito, large, simple trials. That's the way to do things. Thou shalt not adulterate the data. Don't change the data. And then in the United States, thou shalt not take the FDA's name in vain, because that's what, if you're a pharmaceutical company, you want to get your drug approved in the United States. So this is tongue in cheek, but this is actually a lot of what we're going to be talking about in the workshop. Yeah. So the RCTs have good things, they have bad things, and they have ugly things, right? So you can establish causal relationships done in a true control with standardized protocols in a homogeneous set of units. We're doing a real experiment. A trial is an experiment. We have high internal validity. And the best thing, if you randomize a lot of people, is that not only the known confounders are dealt with, but those unknown confounders. And that is what makes these things work so well. But some people will say this is totally artificial. It does not apply in real life. We will talk about pragmatic trials, okay? So they're usually done in a very highly specialized clinical center in high and middle income countries with resources. Oh, so if it works there, does it work in my low income country where I don't have the resources to do all of these sorts of things? This is something we have to think about. Results may not apply in less sophisticated settings or to the general population. We've done all these exclusions and inclusions, and we studied a very narrow artificial group of people with the condition. Does it apply to other people with the condition? So that's very poor external validity. The ugly part is that they may be complex, they'll cost a lot, take a lot of your time and effort. Okay? And we'll talk about that and the implications of that as well.